Hello, this is the presentation for Coccydynia. I apologize, I forgot to push record during the live presentation, so this is a re-record. I apologize for any animal sounds you may hear in the background. My name is Lieutenant Ebony Jackson Clark, and I will be the presenter today. So before I begin, here are the photo credits. This is a title slide photo credit, and then each photo credit is actually going to be listed on the slides with the pictures. Here is the table of contents and all the things that we'll be talking about. At the end, I will go over the lab instructions and what we did in lab. So we'll get straight to it. Coccydynia is tailbone pain. Coccyx means cuckoo's beak in Greek, and dynia is a suffix for pain. And coccydynia has several different names, so it's good to be familiar with them. And then a fun fact is that there are two plural forms of coccyx. There's coccyges and coccyxes. So I looked at many articles, and they all said the same thing. The exact prevalence and incidence of coccydynia are unknown, and it may be underestimated due to underreporting and misdiagnosis. So it's more common in adolescents and adults as compared to children, and those who are assigned female at birth actually have a 5 times more likely chance than those assigned male at birth, due to the risk of childbirth and due to the fact that the coccyx is more posteriorly located and therefore more susceptible to trauma. So the risk factors are obesity, having a BMI greater than 27, and that is from the weight from sitting. And then on the opposite end, we have rapid weight loss, which can cause a loss of adipose tissue and therefore less cushioning. Contact sports are going to put the person more at risk for direct trauma. And then osteoarthritis and osteomyelitis, the worry there is of abnormal morphology or positioning, excessively flexed or extended coccyx, or abnormal scoliotic deformity in the coccyx. So traumatic etiologies would include internal and external. So internal is going to be childbirth, and then external is going to be a backwards fall or repetitive microtrauma, such as repetitive or prolonged sitting on hard, narrow, or uncomfortable surfaces. And in about 50 to 65% of cases of coccydynia, there is a history of direct trauma. And trauma can result in bruises, spurs, compromise to the coccygeal ligaments causing instability, subluxation, and even possibly fracture. So non-traumatic etiologies include degenerative changes or herniated disc in the lower spine, which may cause pain to be radicular or referred. And then infections and inflammatory conditions such as arthritis, tumors or cysts, variants of coccygeal morphology, which we'll have a slide on later, hypermobility or hypomobility of the sacrococcygeal joint, and then pelvic floor muscle spasm. So some things we need to rule in and rule out when it comes to the coccyx area are sacroiliac joint pain and inflammation, infections. So over here on this right, I have a picture of a pilonidal cyst, which can cause an infection that's usually caused by an ingrown hair or skin debris getting trapped in an abscess or sinus. There's also shingles of the buttocks or other infections, masses and malignancies, hemorrhoids, right, because hemorrhoids are very close to the tailbone, sciatica, piriformis syndrome, and pain referred from the pelvic floor muscles. An example of such would be proctalgia fugax, which is when the person experiences intense anal spasms causing sharp stabbing pain in the anus. So the presentation of tailbone pain is going to be very localized pain over the coccyx. Person might have recent trauma or insidious onset. But I did put a star there because oftentimes person will have had an accident years ago, as we'll see in my case study, and the pain just never went away. Then we have the pain is worse with prolonged sitting, leaning back while sitting, prolonged standing, and rising from seated position. And then a lot of times they'll say it feels better after a first couple of steps. It will get better with pressure relief, and it may present with sexual intercourse and defecation, both of which I will cover later in this presentation. So to diagnose coccydynia, we're going to palpate the coccyx locate the pain. Check for hypermobility, hypomobility of the sacrococcygeal joint. If there's going to be radiographic images, they're going to be checking for fracture, degenerative changes, or masses. And then in terms of imaging studies, X-ray is preferred, and an MRI is a second choice. The prognosis is that 90% of these cases are going to resolve with conservative care, so that's great. Most of them are self-limiting. Many resolve without treatment. Some, however, do become severe and cause disabling chronic pain, and then some require surgery. That surgery is called a coccydyectomy, and about the complication rate in terms of for infection is about 0 to 50%. So next we will talk about anatomy. We're going to go over the bones, muscles, ligaments, vessels, and nerves. So the coccyx bone is triangular in shape and it is concave distally. It can have 3 to 5 segments, but commonly there are 4. It is fused in most people. The first 3 have a body, articular, and transverse processes, but none of them have pedicles, laminae, spinous processes, or intervertebral discs. So the sacrococcygeal symphysis is a fibrocartilaginous joint. It articulates at the cornua of the sacrum and the coccyx, and in that forms a sacral foramen through which the coccygeal nerves traverse. So here is a bigger picture where you can see the cornu, the sacral cornu and the coccygeal cornu, and you can also see the foramen. So the coccyx does move. The sacrococcygeal joint is a very mobile joint. It flexes with sitting, it extends with standing, defecation, and birthing. And in terms of mobility, I found several different numbers from several different articles, and I just kind of summarized them here. Lorette et al. Said that it has a range of motion of about 13 degrees. Grassi et al. Said that it had about 35 degrees of flexion, 20 degrees of extension. Garg and Ahuja said that it had about 5 to 25 degrees of flexion, and then Borges et al. Said that it had 15 degrees with a standard deviation of 10.2 of rotation during pelvic floor muscle contraction, and then 12.9 degrees with the standard deviation of 10.9 during straining or defecation. So there are 6 types of coccyx morphologies. Back when I learned about it, there were only 4, but there are 6. I will talk about their predisposition towards coccydynia of each type. So type 1 is going to have the least incidence of coccydynia, while type 2 is going to have a somewhat higher incidence of coccydynia, and that one has a slightly more ventral curvature. Type 3 and type 6 have significantly higher incidences of coccydynia, and that's due to that forward angulation and then that lateral deviation. And then type 5 does not have a incidence or predisposition to coccydynia, but it is a significant factor in causing chronic adventitious bursitis in this type. So muscles. So several muscles actually attach to the coccyx. So anteriorly and laterally, we're going to have the levator ani, 2 of those muscles, the pubococcygeus and the iliococcygeus, attached to the coccyx. The pubococcygeus is going to attach to the sacrum and the coccyx, and then the iliococcygeus is going to be at the tip of the coccyx. Now, more superior on the anterior lateral side, we have the coccygeus muscle that is also attaching. And then on the posterior side, we have the gluteus maximus muscle attaching. So keep that in mind in terms of people who are going to get the coccydyectomy or the removal of their coccyx. How is that going to affect those muscles, or at least the recovery of those muscles? So here's a closer picture of those muscles. On the left here, we have the pelvic floor muscles. You can see the levator ani and the coccygeus muscles that I circled here and how they attach to the coccyx. And on the right, we have the gluteus maximus, and we see that it attaches all the way down to the coccyx. So the ligaments. Most of the ligaments here are continuous with spinal ligaments. Anteriorly, we have the anterior sacrococcygeal ligament, and that is going to be contiguous with the anterior longitudinal ligament. posteriorly, we have the superficial and deep coccygeal ligaments, which are contiguous with the posterior longitudinal ligament, and we also have the supraspinous ligament. Then we also have the pilum terminale externum, or the coccygeal ligament, which is continuous with the filum terminale internum and the dura. Laterally, we have the lateral sacrococcygeal ligaments and the sacrospinous ligament, and then inferiorly, there's the anal coccygeal ligament, or RAF, and that provides an indirect attachment to the anus. Here is a close-up picture. On the left, I circled the sacrococcygeal ligaments, the superficial and deep, and then the sacrospinous, but on the right, there's a better picture of the sacrospinous ligament. And then here's the anal coccygeal RAF, that is providing that indirect attachment from the coccyx to the external anal sphincter in the anus. The sacrum and the coccyx are perfused by the lateral sacral arteries. They're shown in red, those two small arteries along the sacrum going all the way down to the coccyx, and they come from the posterior division of the iliolumbar artery. And then we also have the median sacral arteries, which come from the L4 aorta bifurcation site. So the nerves of the coccyx are going to be made of the coccygeal plexus, which innervates the skin of the coccyx and the postanal region, and then also the ganglion impar, which is the terminal end of the paravertebral chain of sympathetic nervous system. And the pelvic sympathetic trunks converge on the front end of the coccyx. So next we're going to talk about physiology. We're going to talk about the coccyx's role in supporting defecation, breathing, childbirth, and sexual activity. So in terms of support, the coccyx is an attachment site for several muscles, as I already showed, as well as ligaments and tendons. It also forms a tripod with the ischiotuberosities and supports weight bearing in the seated position. And then it's going to also have some positional support to the anal sphincter via that coccygeal RAF, anal coccygeal RAF. The coccyx is mobile during defecation, more so than in sitting. So the levator ani muscles, or the pelvic floor muscles, allow for voluntary bowel control. At rest, they're constricting, elevating, and inverting the lower rectum, and during defecation, they're relaxing to allow for the passing of stool, assisted by squatting. So the levator ani muscles, as we learned before, connect to the coccyx. They're doing all this movement and therefore causing the coccyx to move during defecation. And constipation, as well as movement of the stool within the rectum, can press against the coccyx, and that is why defecation can sometimes be painful for people who are experiencing coccydynia. So here are some pictures to better explain. Right here on the left, we see the puborectalis muscle, which is a part of the levator ani. That muscle, when it relaxes, you see here on the right, it allows the rectum, or the colon and the rectum, to be more, the anal rectal angle to be more obtuse. It's more straight, allowing for the stool to pass easier. On the right, here's a picture showing that in relation to the posture on the toilet. So sitting versus squatting. Squatting allows the puborectalis to relax more, stretches out the pelvic floor more, increasing that anal rectal angle. Here's a video showing that in motion. So we see as the unicorn goes into squatting, that puborectalis is relaxing or stretching, allowing the anal rectal angle to increase and the stool to pass. So breathing. The pelvic floor muscles work with the diaphragm for breathing and maintaining intra-abdominal pressure. Pelvic floor muscles contract against increased intra-abdominal pressure to protect the endopelvic organs, and the pelvic floor muscles contract to generate forced expiration in conditions requiring increased intra-abdominal pressure, such as speaking, deep breathing, nose blowing, coughing, and sneezing. And as we learned before, the coccyx is attached to the pelvic floor muscles, and therefore it's moving if the pelvic floor muscles are moving, and that is why there may be some either pain or change in breathing mechanics when someone has tailbone pain. And I will talk more about breathing in the treatment section as well. So in terms of childbirth, the coccyx is the bone that is actually most affected during movement of the fetus during delivery. So the baby comes into direct contact with the coccyx. Sometimes when there are maybe some hypomobility of that coccyx, or it's not able to move, you might even see some bruising or scraping on the baby's head. The coccyx is supposed to move posteriorly, and restriction to the coccyx can lead to bruising, dislocation, or fracture of the coccyx of the person giving birth, or as well as muscle spasm or pelvic floor pain. So risk factors for coccyx injury during birth: if the baby is posterior face-up positioning, greater than 8 pounds and 13 ounces, if there is a difficult or complicated labor, if the person giving birth has a small or narrow pelvis, the use of forceps or vacuum or any instrument-assisted birth, and then any previous coccyx injury. So there are non-flexible sacrum birthing positions and flexible sacrum birthing positions. Now, the non-flexible positions are going to restrict coccygeal movement, and those are going to be basically any position on the back. We have supine, just laying flat on the back; lithotomy, where the legs are lifted; semi-recumbent, where the torso is lifted; and then dorsal position, which is dorsal hook line position. The flexible sacrum birthing positions are going to allow for coccygeal movement. Those are kneeling, standing, squatting, sitting, even side lying. So the benefits of having an unrestricted sacral position are that it's going to allow for maximum coccygeal movement and create a larger pelvic space. So a flexible position is going to allow for 15.7 degrees of movement as opposed to 3.6 degrees of movement of the coccyx, and that's going to affect the widening of the pubic symphysis. So a flexible position is going to allow for 3 millimeters of movement or widening of the pubic symphysis as opposed to 6, and we know that 10 is pathologic. So the more benefits continued are reduction of the incidence of operative delivery, cesarean section, episiotomy, severe perineal trauma, and instrumental vaginal delivery. It's also going to decrease the duration of the second stage of labor, and there's going to be increased maternal satisfaction. So vaginal or anal penetration causes posterior displacement of the coccyx, which can cause discomfort. Certain positions are going to create more pressure against the coccyx and cause discomfort. And then the actual stretching of spasmed or overactive pelvic floor muscles can increase guarding and increase or cause pain. Next, we're going to talk about evaluating for coccydynia. We'll do subjective briefly and then go over objective. So for the subjective, I just encourage that along with normal subjective questioning, consider the etiologies that we talked about before, the presentation of tailbone pain, those risk factors, and then the differential diagnosis of ruling in or out other causes of regional pain, and then always be screening for red and yellow flags. Now, objective, we're going to screen for other lumbopelvic musculoskeletal sources of pain all along the spine, hip, the innominate bones, sacrum, SI joint, the bursa, and the piriformis. And we want to check functional movement screening: squats, single leg stance, straight leg raise, because the coccyx is part of the lumbopelvic complex, and this area is responsible for load transfer. And we want to look at gait, we want to check breath analysis, and we want to consider, do we need to do a pelvic floor evaluation, and that can be internal or external. So there is a test called Foy's finger test for coccydynia, and what you're going to do is ask the patient to point with one finger to their worst site of pain. So the site of pain should be more inferior than low back pain is typically going to be found, and more midline than where buttock pain syndromes are going to be found. And this test is pretty much the same enlisted instructions as Fortin's finger test, which is a sacroiliac joint test. And we have the seated recline test, so the patient's going to recline back about 30 to 45 degrees, putting more pressure on that coccyx. Positive sign would be increased pain or concomitant pain. External palpation, where you want to palpate, locate, make sure that the pain is where the patient thinks it is. See if it is local to the coccyx, or maybe it's being referred from somewhere else. And then if you have the training and are comfortable doing so, you can do an internal examination to check for coccygeal hyper or hypomobility, pain with coccyx mobilization or manipulation, and check for pelvic floor tenderness or pain. Now we'll talk about the treatment, talk about physical therapy, lifestyle adaptations, medications, injections, surgery, and some other treatment options. So the gold standard is conservative treatment. So that's going to include decreased sitting, seat cushioning, coccygeal massage, stretching, manipulation, mobilization, injections or anesthetics, and then postural adjustments. So for the first treatment we'll look at is breathing. And so maybe you've seen a pelvic floor or pelvic health presentation before, and you're wondering, why does breathing always come up? Why do pelvic health PTs emphasize the diaphragm so much? Why are we so obsessed with it? Well, that's for several reasons. One, levator ani and the coccygeus muscles attach directly to the coccyx. These pelvic floor muscles, the diaphragm and the abdominal muscles, work together to stabilize the trunk and the lumbopelvic region, control intra-abdominal pressure, and assist with breathing. So I'm going to go over each one of those individually. So in terms of stabilizing the trunk and the lumbopelvic region, the pelvic floor muscle, when it contracts, the transverse abdominis and internal obliques contract as well. We can try to reduce abdominal co-contraction with pelvic floor muscle contraction, but we cannot eliminate it. These muscles work together. And we have on the flip side, the opposite. The abdominal exercises recruit pelvic floor muscle contraction. This is a feed forward loop that in healthy people should be working properly. B, controlling intra-abdominal pressure. So I mentioned before, talking, moving, breathing, coughing, moving of the limbs. All of these increase intra-abdominal pressure. And A, correct pelvic floor muscle contraction with activation of the deep abdominal muscles prevents increase in intra-abdominal pressure on the organs. Assist with breathing. So when we breathe in, the pelvic floor muscles relax. The diaphragm moves inferiorly to allow more air to enter the lungs. And when we exhale, the pelvic floor muscles, along with those diaphragmatic muscles, or abdominal muscles, they contract or recoil, and the diaphragm moves upward. So the diaphragm moves about 1.5 centimeters during quiet breathing, but during deep breathing, it moves about 6 to 10 centimeters. And if the pelvic floor muscle is contracted during that inhalation, there's actually a decrease in descent of the diaphragm of about 5.6 centimeters. So contracting the pelvic floor muscle hinders the movement of the diaphragm. So you can see here on the right, this picture, the diaphragm moves down with an inhale. The abdominal muscles move outwards with the inhale, and the pelvic floor muscle moves downwards with the inhale. And when we exhale, the diaphragm moves back up, pushing the air out, and the abdominal muscles and the pelvic floor muscles recoil with it. And so this is a range of motion exercise for the pelvic floor. Other benefits of breathing, I just mentioned that it's a passive range of motion for the pelvic floor muscles and the coccyx, but which can help lengthen and relax guarded, tight, or spasmed muscles. There are other mindfulness benefits of deep breathing. It can reduce physiological and psychological stress by decreasing blood pressure, heart rate, and cortisol levels, or stress hormone. It also can improve the respiratory function and respiratory muscle strength, and then it does enhance cognitive performance via sustained attention. So now on to mobilization treatments. So Mohanty and Patnick found that thoracic mobilization is actually effective in helping with tailbone pain. And their reasoning behind that was that it's increasing thoracic extension and sacral rotation, and therefore reducing stress on the sacrum and the coccyx. Then we have coccyx mobilization. So this is recommended for patients without pelvic floor spasm and who have stable coccyges, which was defined as less than 25 degrees of flexion and less than 20 degrees of extension in sitting compared to standing. And then there's also some, there are internal and external ways to mobilize the coccyx. So internal, we're going to have anterior, posterior, or lateral oscillations, distraction, and manipulation. But there's also an external technique for those of you who do not do internal, and it's called the stuck drawer, and I will go over that in the lab portion. Then we have, with the pelvic floor muscles, we can do soft tissue massage and instrument-assisted soft tissue mobilization, myofascial release, or even scar mobilization. So this is going to be to decrease the levator ani coccygeal muscle spasm. It's going to decrease aggravation and degeneration of the sacred coccygeal joint. This can be done internally, externally, and if you have dry needling skills, it can be done that way as well. In terms of abdominal, we can do soft tissue mobilization, scar mobilization, and cupping, and this would be to decrease constipation and to either restore or improve breathing mechanics, because we saw that both of those are related to or affect, both of those are affected by coccygeal mobility. Then we have stretching. In that same Mohanty and Patnick article, they did these stretches. They did a piriformis stretch. Reasoning behind that was to decrease sacral rotation and reduce dysfunction of the coccyx and the sacrum. And then they did an iliopsoas stretch to decrease anterior pelvic tilt and lumbar lordosis, increase hip extension, and then decrease sacral counternutation, which it was to decrease abnormal loads in the sacrum and coccyx. And some other stretches are going to be the happy baby, cat-cow, child's pose, and knee to chest pose. And those are going to be to lengthen guarded, tight, or spasmed muscles, and then also just to improve the flexibility and mobility of muscles that attach to or work synergistically with muscles in the lumbopelvic area. And then I added a glute stretch because just to propose, like, should we stretch the glutes? They do attach to the coccyx. Would that help? Here are some pictures of the piriformis and iliopsoas stretch as they were mentioned in the Mohanty and Patnick article. Obviously, we can do them in different positions for the different positions, finding what works best for our patient. Here is a happy baby stretch. This is an advanced form of happy baby. I usually have my patients put their hands behind their knees, and then I want their legs to be completely relaxed. It's okay that their arms are doing all the work. If their legs are not relaxed, their pelvic floor is probably not relaxed. And then on the right, we have the cat-cow circled here, the lumbar area. A lot of people, including this person in the picture, have a lot of mobility in that thoracic area, and then the lumbar area is not moving at all. So I think it's pretty important to emphasize trying to get that lumbar area to flex and extend. Some neuromuscular re-education treatment options for the pelvic floor include down training and relaxation training, and we want to do that to restore the length, tone, range of motion, and strength of the pelvic floor, as it does attach to the coccyx and sometimes can be the source of pain in coccydynia. And that can be done internally or externally, or even with surface EMG biofeedback. Some therapeutic exercises. So we want to consider all of the lumbopelvic muscles, the hip extensors, abductors, adductors, external rotators, flexors, and the deep abdominal muscles. And because of their impact on the pelvic floor, right? they help control the trunk, and they help provide stabilization to the lumbopelvic area. And then dysfunction of lumbopelvic muscles can affect pelvic floor muscle function. And this is a slide from my last presentation about lumbopelvic pain and pelvic floor dysfunction. The pelvic floor is a key lumbopelvic stabilizer, and pelvic floor dysfunction can be affected by poor posture and dysfunction of lumbopelvic stabilizers, such as the hip flexors, extensors, and abductors. And reduced lower quarter flexibility, range of motion, strength, and load transfer deficits with pelvic movement are lumbopelvic deficits that contribute to regional biomechanical dysfunction, and compensation of that contribute to pelvic floor dysfunction. So this is just to re-emphasize the link between the pelvic floor and the lumbopelvic area. They work together, and dysfunction in either or can affect the other. So some lifestyle changes would be seat cushionings. So wedge-shaped or U-shaped cushions are actually better than the ring or donate-shaped cushions. The ring or donate-shaped cushions can increase pressure for some patients and cause more pain. There's also the option to use towels to be creative and rig up something to help reduce that stress on the sacrum and the coccyx. Then there are hot or sitz baths, or hot or cold compresses, and that would be to reduce muscle tightness or spasm. And then we have postural adjustments. Sometimes patients are sacral sitting. They're putting more pressure on their tailbone, having them lean forward into neutral, not necessarily into an anterior tilt, but into neutral, can help reduce some of that stress on that sacrum and the coccyx. More lifestyle changes are going to include reduced sitting time, which we should be doing in general, wearing looser clothing, and then constipation management. So constipation management, there are several different steps to that. We have toileting posture, we saw with that squatting or having the knees slightly above the hips. Diet and exercise, bowel massage, which is shown over here. There's plenty of YouTube videos that you can watch or show to your patients. They can do this to themselves, or you can do it to them. Stool softeners, and then finally defecation training, which would be part of pelvic floor physical therapy. But as you can see here, there's 1, 2, 3, 4, 5 different things for constipation management that can be done without doing anything internal. Then we have medicines, injections, surgery, non-steroidal anti-inflammatory drugs would be the medicine. Then injections can be used for both diagnostic reasonings and treatment. And then surgery is considered a last resort. And then here's some other treatments. I'm not really going to go into them because other than TENS, they're not really treatments that we do as a part of physical therapy. Okay, so the case study. So I got a consult for a patient with sacral pain that started after her pregnancy 4 years ago, but she also had a history of tailbone trauma from 20 years ago. Now, when I talked to her, she said that she'd had tailbone pain for 22 years after slipping on stairs, which had resulted in a hairline fracture. She had been unable to sit normally ever since then. She'd been sitting off to her side when sitting, and the pain became worse after the birth of her second child. She experienced pain when getting up after sitting for about 15 to 30 minutes. She described it as a burning, aching pain that went away after 3 to 4 steps. She slept on her side with her butt off the bed to relieve the pressure off of her tailbone, but she notices that caused back pain, low back pain. And then she also reported some occasional hip pain and that she had right heel spurs. So her medical history included diabetes, hypothyroidism, obesity, migraines, chronic thoracic back pain, gastritis, and sacral pain, and wasn't listed, but she'd mentioned the low back pain from the sleeping posture. Obstetric and gynecologic history, she'd had 2 vaginal births, 8 pounds and 6 ounces and 6 pounds. She did have some bladder symptoms, some leaking with laughing, coughing, sneezing sometimes. And then musculoskeletal, she had low back pain and tailbone pain. In terms of ortho, I'm only going to list the significant findings. She had bilateral knee valgus with single leg squat, bilateral Trendelenburg sign. She had a little bit of weakness on that glute, in those glute medials, some tightness in those hamstrings and the hip flexors. And then she did have pain with PAs at L3. And then her pain was local to her coccyx and a little bit into the inferior sacrum. So in terms of significant findings during my pelvic floor examination, she had some redness and skin tearing at the superior coccyx externally. And that is something that I have noticed and something that I learned about during my residency that may be attributed to possible tightness of the muscles in that the pelvic floor muscles in that area. She also had some perianal hemorrhoids, so that could, that's a sign for possible constipation or previous history of constipation. She did have pain at several muscles in her pelvic floor, superficial and deep muscles, and that obturator internus, that OI, which is also a hip muscle. And then in terms of strength of the pelvic floor, she had a 3 out of 5. Good ability to relax, but difficulty bearing down or lengthening of the pelvic floor. And then poor endurance and poor coordination. So on to treatment. So during the eval, I did a little bit of myofascial release to her pelvic floor. And then I did some external, it was actually instrument-assisted soft tissue massage to the coccygeus externally. And then we did diaphragmatic breathing. When she came back, she actually said that she thought the breathing helped significantly with her pain. And then on her third and second visits, and here I've bolded the things that I've added. So if it's not in bold, that means we did it the last time. We added some pelvic floor relaxation to that diaphragmatic breathing. We added some pelvic floor coordination as well, and then I added some stretch for the pelvic floor, and then I went ahead and started some strengthening of the hips, just because she had that weakness in her glute medials, and then also she had that pain in the OI, the obturator internus, which is the hip external rotator. So if I find in either of those, I immediately start strengthening the hip extension and external rotation as well as abduction, because I find that often that at least for the obturator internus, that muscle will be tight and cranky because of weakness. And once we start strengthening it and training it, that pain starts to go away. For her fourth visit, I just added 2 more stretches. We did the same things as before. And for the 5th visit, I added another pelvic floor elevator. I use that as a neuromuscular reeducation and coordination and relaxation exercise, and then I added another stretch. Then on the 6th visit, I had taken away the external, that soft tissue mobilization, so I added that back. And then we added the cat-cow for some range of motion, and then I progressed that hip strengthening exercise to added the external rotation. The 7th visit, I showed her how to use a flex bar, which is a tool used for the forearms wrist strengthening. I use it as a tool for self-massage. You sit on it vertically like a bike seat to have it angled off a little bit, put it right inside that ischial tuberosity. Sitting on it, the patient can rock gently forward and backward or side to side and get a nice external massage to the pelvic floor. Then added some more pelvic floor exercises, added some more hip exercises because she actually did have some hip pain, as I mentioned before. And then I added functional therapeutic activities. We started doing gait with glute activation. So I do like to move things off of the plinth because I think it's more sustainable for the patient, and then it's obviously more functional. So that 8th visit, added some more hip exercises for her hip pain, and then that 9th visit progressed that gait with the glutes, the abdominal and pelvic floor activation. And then her 10th visit, we practiced the gait, those exercises on a treadmill. I find that patients pick it up quicker on the treadmill, and they are forced to walk normal instead of walking like a robot on the treadmill. And then I also added, just emphasized relaxation again, because we're doing a lot of squeezing. Want to make sure they're not just squeezing the pelvic floor all the time. It needs to have the full range of motion. And then the 11th visit, or our final visit, we just did the functional, that gait. So the results of this treatment were that the patient had a reduction in pain and tenderness to touch palpation after the first session, which we did manual therapy and diaphragmatic breathing. She had a good response after each session to the manual therapy. She always had less pain, and she had good response to the neuromuscular reeducation each session. She had less muscle tension each time, and better control and coordination of those muscles. The patient's tailbone pain gradually reduced from constant to only when she sat for prolonged times on soft surfaces. She reported resolution of her urinary leaking completely. She was able to sit normally on chairs instead of sitting sideways off to that side like she had been, and she was able to lie on her back in bed for sleep instead of having her butt hanging off the bed, increasing her low back pain. So I created a cheat sheet that has all of this information synthesized into one page, because I thought that would be helpful. That's what I would want after a presentation. And then I will send this out to those who finish the post-test, and you'll get your certificate in the cheat sheet. So that concludes the end of the lecture part of the presentation. Next, I'm just going to go over what the lab was, what we did. So first we did diaphragmatic breathing. So when I teach diaphragmatic breathing, I am looking for expansion of the ribs and the abdomen, not just the stomach coming out, and not just anteriorly. I'm looking for anterior, lateral, and posterior, a 360-degree movement. I actually love to use the balloon to help demonstrate to my patients. So the mouth of the balloon is the person's mouth. When the balloon expands, that's them breathing in. Their belly is expanding out. And we have that pump handle and that bucket handle movement of the ribs as well. But we do want to avoid rib flare. And then when the person expands, everything shrinks just like in a balloon. So here are some good gifts of what this should look like. So the chest and the belly are expanding. In that right picture, the glutes are expanding. I'm not sure why. I cannot guarantee those results. But it's a nice 360-degree movement here. If the person has a smartwatch, iWatch, there is a breathing app on there. I forget what it's called. That has a nice visualization that the patient can just follow along for the pacing. I believe it's only a minute, so I really like to use this video here. If you just copy and paste or type this exactly how it's written here, you'll find this video. They have a 5-minute and a 10-minute version. I usually tell my patients to do the 5-minute version, and it's a visualization similar to this one of inhaling and exhaling, but it also has the sound of someone inhaling and exhaling. I love it because it takes away the patient having to think about their pacing, which sometimes throws the people off a lot, and they can just focus on getting the belly and that chest to expand. So during the lab, we did the happy baby, cat cow, and child's pose, and I wanted those to be taught with an emphasis of pelvic floor and coccygeal relaxation or stretching, and then lumbar mobility. So with the cat cow, having the patient on their hands and their knees, you're blocking their thoracic spine with your arm and having them really try to get that flexion and extension coming from the lumbar spine, and having that pelvic anterior and posterior tilt. If you have permission, using your hands to help reinforce that tilt. Okay, and then you can also add breathing to all three of these. So with the happy baby, you're on your back. You have your hands under your knees, or in your popliteal space, bringing your knees back towards your shoulders, your chest, and out towards your shoulders, and then as much as is comfortable for the patient. And then doing the diaphragmatic breathing in that positioning, really feeling for a subtle expansion, descent of the pelvic floor, and then letting it recoil with exhale. And then same with child's pose, except having those knees wide to allow for the butt to come down towards the heels, the arms in front. If the person has poor hip mobility, putting multiple pillows under their chest so that their butt can relax back down towards their heels. The stuck jaw technique, so you're sitting next to the patient. There is a video of this, a really great video by Michelle Lyons on YouTube. You're sitting next to the patient. You have your middle finger directly over the coccyx, so it's pretty low. Will probably be between the buttocks. Your hand will be gloved. You're going to do posterior to anterior mobs, and so that's going to happen when the person slumps. Okay, and you're going to follow the coccyx with that middle finger, and then when they sit up, you're going to distract on the skin and pull posterior superiorly as they extend their lumbar spine. And then we can add breathing to that. When they slump, they're exhaling, your fingers following their coccyx forward, and when they come back into lumbar extension, they're inhaling, and you're pulling posterior to anterior on that coccyx. And then you can also assess the pelvic floor in this position. So tell the person to stop the pee, stop the gas. You should feel the coccyx floating forward. And then whenever you have them relax or release that squeeze, you should feel the coccyx floating back towards your finger. Okay, and then you can add that to the stuck jaw. So when they exhale, they slump, they squeeze the pelvic floor, your finger follows the coccyx, and when they inhale and come back upright, they relax or let go of that squeeze, and then you're help pulling the coccyx back. And then in the upright position, you can add side bending as tolerated by the patient. This is an internal coccyx mobilization technique. We didn't do this in lab, but I wanted to show it. So you're going to do intrarectal or intravaginally, one finger internally or one finger internally and one externally to do distractions, PA mobs, and lateral mobs. Then for pelvic floor muscle mobilization, I prefer to do this externally and or externally and internally. So I use the instruments assisted soft tissue massage. I use the instruments to mobilize the soft tissue in that space between the sacrum and the ischial spine. I do go around the entire area, but I'm kind of targeting that sacrospinous coccygeal area because a lot of muscle tension can be held there. And then internally, you would just use a finger, and then you're just doing soft tissue massage and myofascial release in that area. These are the tools I use to do that. Just because that space is pretty small, these tools are a little bit easier to target that space. I also will sometimes use the tool that looks like a brass knuckle as well. And then when it comes to neuromuscular reeducation of the pelvic floor muscles, because these muscles can be guarding, can be tight, can be cranky and painful. The diaphragmatic breathing, which we already went over, the diaphragmatic breathing in the happy baby, which we already went over, and then if the patient is in recline position, they can self-palpate by reaching around and feeling right in medial to that ischial tuberosity. As they're breathing, can they feel that slight, subtle expansion of the pelvic floor? And then as they exhale, it just recoils caudally. Okay, and then if you for pelvic floor contraction and relaxation, so one way to do this is in sitting with the towel, a rolled up towel, sitting on it like a bike seat. Have the patient have it against their perineum, And then this will give them some biofeedback of whether they're using the correct muscles. When they squeeze or stop the pee or stop the gas, they should feel a tension and a lifting off the towel. And then they relax or release that squeeze. They should feel the pressure coming of the perineum coming back down onto the towel. And then just be sure, if you're teaching this, to have them differentiate between a glute squeeze and a pelvic floor squeeze. The last two are more pelvic floor PT techniques. So those first four, you don't have to do any internal. You can do palpation over the clothes or with that towel, as I just described. So here are my references. Please remember to do the post test that was sent out with this email, and then that way you can get your CEU credit as well as your cheat sheet. If you have any questions, you can just email me. Thank you for attending this class.